Okay, we are back with another episode of Claims Denied, a Hospitalogy podcast. Today, super interested in our guests, two experts in the mental health space, both with payer and provider experiences from Birches Health, Elliott Rapaport and Dr. Doug Nemecek. Guys, thanks so much for coming on. Maybe would love to start with an introduction from both of you, your journey through healthcare, and we can maybe go from there. So, Elliott, maybe we can start with you and then round out with the doctor.
Yeah, of course, Blake, and thanks so much for having us. We're incredibly excited about this opportunity. So I'll give a little bit of background on myself, then can dig into Birches Health and what we've accomplished over the past 3 years or so. But I've been in behavioral health care now for the past 7 years, always focused on increasing access to care for these really underserved patient populations. So I ran the book of business at a large autism care company, working both in the commercial insurance and then Medicaid space, really focused on ensuring that pediatric youth and adolescent patients had access to autism care. And then I started Birches Health now 3 years ago because I had a friend who more than a decade ago, and actually in our undergrad, was in and out of treatment for gambling addiction, for problem gambling. And back then, and this was kind of a 2012 to 2016 timeline, your options for getting specialized treatment for a behavioral and a process addiction, of which, of course, gambling disorder is one of the largest ones, your options were a 1-800 number or going to the literal or kind of metaphorical community center basement, the local YMCA, the local church basement, so to speak. And while both of those pathways for patients are a great fit, for some, they don't work for everyone. And increasingly, they don't work for a lot of the 18 to 40-year-olds across the United States today who are increasingly at risk of becoming addicted to online sports betting, online gambling, online day trading and financial market products, things like that. So we started Birches Health in 2023 to scale specialized care for behavioral addictions, gambling, video gaming, sex and pornography addiction, and internet, online, and social media addiction. And we've been very fortunate to build out a model that really seems to resonate with payer partners, providers, and of course, and most importantly, individuals and their families who desperately need access to this specialized care.
Yeah, I
Awesome.
love that. Doug, go ahead.
Yeah, thanks, Blake. And it's really great to be here with you today and talk about Birches Health and what we're doing. I am Doug Nemecek. I am a psychiatrist by training. I am now a senior advisor with Birches Health. I prior worked and ran a large mental health and substance use practice in Minneapolis and St. Paul, Minnesota for many years. And then I switched over to the payer side of the industry, and I was with Cigna Healthcare and Evernorth for over 20 years, and much of that time as the chief medical officer for behavioral health. And while there, one of the things that I really recognized was the transition over time as we were getting better at really personalizing care for people with mental health and substance use issues, and really then the opportunity that we have to truly help people get to specialized care for whatever mental health symptoms or substance use issues they may have. And that's what's really gotten me excited about working with Birches Health and the opportunity to really focus on individuals with gambling disorders and things like that. So great to be here.
Yeah, thanks so much, guys. And mental health is something I'm super interested in, especially as it seems like we're seeing more integration and awareness and those sorts of things, and those are all wonderful things. Would you mind, Doug, maybe starting with you? I would love just maybe like a top-down, like macro view of how you would assess kind of like the state, like the landscape of mental health today. And then maybe you could contextualize that within like Birches Health and what you guys are seeing with these addictions specifically.
Yeah, so I think one of the ways I would describe the change and the evolution that we've seen in the mental health ecosystem over the years really is that probably 20 years ago, when I first moved from practice to the payer, we didn't really talk about mental health or substance use at the time because of stigmas, because people didn't know what to do with it. Primary care doctors didn't ask you about mental health symptoms or gambling or any of those things. And it was a disconnected world. And really what individuals had a lot of trouble then accessing care or knowing what to do or how to find care because it just was disconnected from traditional medical care. Over the last, 10 to 20 years now, what we've seen is that people are much more aware of mental health. People are much more willing to talk about what's going on with them. You much more likely to hear somebody in public say, "Hey, I've got anxiety," or "I have an eating disorder," or "I've got a gambling problem," right? And people much more willing to seek help. With that, and this was really, I think, accelerated by the pandemic that we went through, was the fact that everybody got anxious and depressed when we got locked up at home, and B, it forced us all to look at technology and how we could make access to care easier for everybody, and bringing virtual care really to market. And what we saw was we went from maybe 1 or 2% of people who were getting mental health treatment or substance use treatment virtually, digitally through their computers and phones, to over 50, 60, 70% of people accessing their mental health care that way. And that has really continued even past the pandemic. And so with those changes, with virtual care now being common and accessible, people more willing to access care, employers are paying more attention to their mental health and substance use benefits to make sure their employees are getting the care that they need, and as well as recognizing the impact that it's the entire family, it's adults, it's children, it's adolescents, and everybody who has issues, and making sure that we are putting together a system of experts and specialists and high quality care that can really deliver for people when and where they need that help.
Yeah, that's fascinating, Doug. So I would love to dive into that a little more, because as people are realizing they have mental health issues and are more self-aware, and that's great, that vulnerability, just from the pure like business side of running a health insurer, like more access means more utilization, right? And so something I've always wondered is, especially with something maybe a little more fluffy like mental health, like how do you kind of justify spend in certain areas and find like sustainable models, and like what do you kind of index on and those sorts of things? Because it's not as cut and dry as a surgery, right? Did the patient get better, or they readmitted, or whatever it is? Well, how does that translate into mental health, if that makes sense, like that cost access balance?
Well, certainly payers spend a lot of time looking at the cost of the care and the cost of the benefits, right? And historically, mental health and substance use was a very small percentage of the overall medical spend at payers. It still is relatively small, but on a year over year trend basis, what we've seen, or what payers have seen over the last 5 to 10 years, is really an increase in the cost of mental health and substance use care, as more people have reached out for help and recognized that they need help. As a psychiatrist who was in practice long before that, even, we always knew there were lots of people who needed help that weren't getting it, either because they were afraid to ask for help, because they didn't know where to go to get help, whatever it might be. What we've seen now, as people are finally getting help, that's a good thing. We also know, and payers are also aware of the fact that as people have both medical and mental health issues often together, and they impact each other. For example, people with diabetes, twice as likely to be depressed. You're also, if you're depressed, twice as likely to end up with a diagnosis of diabetes, because when you're depressed or anxious, you don't take care of yourself, and you don't eat right, and you're not able to exercise and do the things you need to do to take care of yourself. So payers have started to understand that and recognize that getting people appropriate mental health and substance use care ultimately is better for each individual's health, and ultimately supports that total cost, that total medical spend that we see across insurance as well.
And I think it's an incredible point, and want to jump in on something. So Dr. Nemecek and I were recently at a conference, and I'd love to give credit, but I don't know who the person was who made the comment. But it was a soundbite, which was basically like the problem 5, 6 years ago was access, and the problem today is access. And obviously, shall we say, differing definitions of the word access, I think, in that. But just as it relates to the topic today and specialty care in general, I think providers are very much focused on kind of the idea of access too. If you're a specialized provider, you want to see patients who fit within your specialty. As in, you want to ensure, for us at Birches Health, we've scaled nationally. We're very fortunate to work with the vast majority of commercial plans, national and regional in the US. We want to ensure that people who are addicted to gambling and sports betting, who have the clinical diagnosis of F63.0, are reaching out to us. We don't want to see people who have a primary condition of SUD, of a more general mental health disorder. And I think it's definitely an ongoing conversation with payers about how can we ensure that the right people are getting routed to the right care, because that's what ends up saving people money when specialized clinical models are able to treat patients who need that care. It works better.
Yeah, love that. Absolutely. That is funny. It's an access problem before and it's still an access problem. And so, with this context in mind and, payer interest in mental health and everything in between and finding sustainable balance, Elliot or Doug, either one of you would love for you to dive into the Birches Health model, like how it was formed, how you partner with payers, why addiction, prevalence of the disease, like those sorts of things, the thesis kind of behind it. I would love to hear more.
So I'm happy to take that and to just set the scene a little bit, set the stage rather, I think, for the founding and growth of Birches Health. And then Doug, I think I'll hand it over to you to talk a little bit more from kind of the payer perspective, why this is compelling. So as of today, you have 39 states in Washington, D.C. that have legalized sports betting or online gambling in some form. However, individuals in all 50 states, as we know, often find ways to gamble, to bet, to trade online. There was a recent APA research poll, which I thought was fascinating, which shows that more than 1 in 4, about 28% of adults actually have a daily habit of gambling online. And you're seeing gambling in the under 25 cohort, so about 18 to 25-year-olds, which is actually growing about 15% year over year for the next 5 years. So gambling, as we all know, is truly here to stay. And I think we exist in a world where anyone on this call could actively be placing bets even as we speak. And when I say bets, and in merely the entry point thinking about gambling, it doesn't even include the gamblification of financial trading apps, of cryptocurrency platforms, even slot machine mechanics, like loot boxes in video games for children. So Americans today, we can bet on anything. I think what a lot of people don't know, and I think why a lot of payer and health system partners have started to really focus on this problem a little bit more, is that as more Americans get addicted to gambling, gambling disorder is amongst the highest rates of suicidality and behavioral health, as well as compounding financial issues. So you'll see about 18 to 40% of gambling disorder patients who experience suicidality. And then you'll see about a third, almost 30% of bettors who attribute personal debt directly to their gambling habits. So when we think about, from the provider side, really solving a gambling disorder epidemic, Birches Health's North Star is combating gambling addiction and these related behavioral disorders and really the significant harms that arise from them using very proven, specialized method of measurement-informed care. Individuals and their families, we believe, should no longer have to suffer in silence.
Yeah, that's awesome. I love that so much. And I'm curious, Doug, as a psychiatrist, because I feel like it's hard to know, like whether, and I'm talking more from the consumer standpoint here, whether somebody is like addicted or it's just like a hobby kind of thing. Like, how do you define addiction?
So addiction is really defined as somebody who ends up having a compulsive need to follow this behavior, use this substance, whatever that might be, right? At a very high level. There are diagnostic criteria that are used today. We've got what's called the Diagnostic and Statistical Manual of Mental Health and Substance Use Disorders. And there are criteria that look at someone's use to differentiate, hey, is this just social gambling that many people do very occasionally, or is this something that's a problem? And it gets into things looking at, do you feel like compulsively you have to gamble? Is it causing problems in your life? Are you needing to lie about your use and hide your use or your gambling from other people? Is your use or your gambling from an addiction perspective getting in the way or causing problems with work, causing problems with your relationships, with your marriage, with your kids, whatever it might be? And those sorts of complications and problems that arise from addiction or gambling are the things that start to add up to say, yes, you have enough symptoms here that this is diagnosed as a gambling disorder or some other addiction. So that's how we make the diagnosis. Interestingly, what I would say is that as gambling has become more prevalent and the ability to gamble has gotten easier, we're starting to see this more and more. And Elliott laid out all the statistics that show the increasing prevalence, right? I think the other thing from a mental health disorder perspective is we know across the board really that 75% of people will have symptoms of their mental health disorder by the time they're 25 years old. And 50% even in adolescence by age 14. With gambling, especially here again, more than a third of people age 11 to 17 today in studies say that they have gambled. They have placed bets, right? This is adolescents who are high risk and at higher risk to get addicted to the behaviors than an adult who maybe gambles occasionally or recreationally later in their life. So this is really something that's developing and becoming more prevalent. And as we see kids aging into this from a technology perspective and the ease of use, really something that we're paying attention to. And then the other piece of that I would say that has really brought this to the forefront from a broader mental health perspective and from the payer side is that employers are starting to see the problems that spill over into the workplace from a productivity issue, from an absenteeism issue, and the other healthcare issues that come along with somebody who has now developed a gambling disorder. So people with a gambling disorder have higher risk, as Elliott said, for suicidal ideation and suicide attempts, but they end up in the emergency room more often. They have financial problems, so they're not taking care of themselves. They maybe aren't taking their medications for their blood pressure or whatever else is going, their asthma, whatever their conditions are. All of those conditions get worse as well. And so all of that is spilling over into the health plan as well as into the workplace. And so employers are starting to come to payers and say, hey, I've got a problem in my workforce that I need help making sure that we're addressing.
There's a part of this as I was thinking about kind of prepping for you guys. I've seen some videos and I mean, I've seen in my own experience, I've seen advertisements for, the FanDuels and the DraftKings and every Polymarket now, all these things. Polymarket was on the side of the NHL playoff game last night. I just finished making a chess move on my chess app and I got another advertisement. They're everywhere. And I feel like it supports a lot of the economy or certain, media functions or whatever that is. But then when people compulsively use those platforms, it benefits them, right? And so I'm curious for y'all's perspective, like, I don't know, it almost feels like, the payer and someone like Birches is left kind of picking up the scraps of these people who have been exploited. But then on the other hand, I think about this, the consumer should have choice, right? I don't know. I'm curious, like, have you guys thought about that dynamic and in an ideal world, I would think that you could somehow screen or filter out those advertisements or whatever for like an addict, like if you have a diagnosis or something. But like, how do you guys think about all of that mumbo jumbo?
Yeah, it's a question which I think our society is obviously wrestling with when you think about the consumer-facing prevalence, but then also, and I'll talk a little bit about this, even kind of the quantitative prevalence too of gambling disorder. Now, about 2.5 months ago, you had the Super Bowl. I believe you had about 70% of Americans, so call it 250 million Americans, who bet, if not more, on the Super Bowl. And so gambling, again, is very here to stay, very much here to stay, but you'll always see people who just cannot engage in a healthy and sustainable way. And so for everyone for whom gambling is community, it's a way to let off steam with your friends, it's losing $10, $20. There are people who are losing thousands, hundreds of thousands of dollars. And I think, as Doug was saying, more importantly, even the relationships, the family unit, the trust of their community and even their lives. And so that's who we are very much focused on serving here at Birches Health. But digging into the prevalence numbers, because this is really interesting to me. If you Google gambling disorder prevalence today, you would see a number for the general population, which is between about 1 to 4%. And these numbers are from an early, I believe it was early 2000 study, which is the last time that a true national prevalence study was given. That meant back in the early 2000s that I, sitting here in New York City, would have needed to get on a Greyhound bus and, take the 4-hour drive to Atlantic City, to Connecticut, to physically be able to bet on table games. Today, gambling has been radically redefined, and each one of us can gamble, of course, from our phones on a moment's notice. So you're starting to see some early prevalence data emerge, and there was a prevalence study from 24 to 25 in Pennsylvania, which was one of the first states to legalize online gambling back in, I believe it was 2019, 2020. And what it revealed is that about 2.5 to 6.4% of the general population, 13 million, 14 million Pennsylvanians, they were significantly at risk and exhibited the criteria, the diagnostic criteria, like Doug was talking about, for gambling disorder. And then you had another about 20 to 30% who were at risk of lower acuity problem gambling. And so you cut those numbers, and this is obviously one of the states where gambling and online gambling is at the time to set in. And that number reveals that about a third of the state could be at risk of a gambling addiction. And that number is a lot higher than the 1 to 4%, which you see in a prevalence study. And so a lot of this, I think, is that, frankly, online gambling just hasn't been around as long as some of the other costs of care on the behavioral health side. I'm thinking eating disorders in particular, probably. And so a lot of this will just continue to bake, but is already starting to show up in the claims data when you think about it from the payer perspective.
Go ahead, Doug.
I was going to say, to add to that, I think it's interesting as a psychiatrist who was seeing patients for many years now. Gambling wasn't something I was trained in when I was in my training, right? I'm a board certified psychiatrist. I've been to lots of continuing education courses over the course of my career. This gambling really wasn't an issue necessarily that was discussed very often. And then on the payer side, what you saw is, especially 5 years ago, but even to some degree up till today, if you ask payers, how many claims is a payer getting with a diagnosis of gambling disorder, like Elliott was talking about? And they'll say, hey, we don't really see that in the claims. It doesn't look like anybody's getting care. It doesn't sound like it's a problem with my membership, right? The problem with that is not that people don't have the disorder. It's not that they're not seeking care. It's that when somebody finally sees them and starts to treat them, they just say, oh, they're depressed, they're anxious. And that's the diagnosis that gets submitted to the insurance company. That's what pays the claim and those sorts of things. And so we just don't have the data there on how many people actually are seeking care. Yes, maybe it was the depression that they couldn't get out of bed anymore because they were so racked with guilt over their gambling history and financial problems. But it's the gambling that's the root of that, and what really needs the ultimate treatment. And so we're at a point now where putting that all together is really important, and so that we can identify and find the people with the gambling disorders and get them to specialists like we have at Birches so that they can get the care that they need.
Yeah, I love that. That's just so interesting. We talk about these prevalency numbers, and just as somebody who's like studied addiction from personal interest, a lot of addicts don't seek help unless they're forced to and or like hit like a rock bottom, right? And so maybe a lot of people aren't even like self-reporting. And I'd be curious, like I would be of a personal opinion that prevalency numbers could be even higher than publicly stated from those initial studies. And something else I'm curious about is I've heard some people say that all forms of addiction are kind of a form of gambling, in the sense that you're like thinking about like the trade-offs of your actions essentially, right? Like from a compulsive standpoint. And so I would also be curious to know actual prevalency numbers of the other process-based addictions too, not the substance-based ones, like the sex addictions and the online and those sorts of things. So I don't know. I do think I'm of the personal opinion that addiction is probably a lot more widespread than we think. And so back to kind of Birch's Health, I'm curious, like, what do you guys view as like this the best standard of care for different treatment pathways across various addictions, and like how do you measure those and those sorts of things for your payer partners?
So at Birches Health, we think about care in two phases, Blake. And the first few months, we really think of them as acute clinical intervention, getting someone out of crisis, building coping skills, at times addressing the immediate financial wreckage. And we see individuals who, again, to use that word, really enter our program in crisis. They've lost the big bet. They've gambled away this month's rent, this month's groceries, graduate students who've gambled with their loans, things like that. So it's really focused on stabilizing someone. But I think the big focus, and in many ways, not to give it all away, but kind of the secret sauce of our clinical model, is really on month 4 to year 40, as we call it. We're not trying to get someone through a 6-week, a 12-week program and then send them on their way. We're actually helping them build a life where they can maintain recovery without Birches Health. Some people might step down to less intensive support after a time. Others, of course, stay engaged longer. As we all know on this call, there's no cure for addiction. You're in and out of periods of recovery throughout your life. But either way, I think what we really focus on with our patients is building the foundation for decades of recovery, not just treating an immediate crisis. And within the spectrum of behavioral addiction, you'll see behavioral addiction episodes last for about 6 to 10 years on average, and people going in and out of care. And so it's really focused on a foundation and empowering people to move on from Birches Health, knowing, of course, that we will always be here. And payer partners thus far have seemed to reinforce and support that, which is why we've been able to grow as quickly as we have.
And I think that's an interesting point about addiction cannot be cured. You're kind of in and out of like flux, right? And something can trigger you, et cetera. And so you guys are building programs to help folks manage those things. And I imagine, helping to foster like community and connection and those sorts of things as well. But I'm curious from like the payer perspective, that's interesting, right? Like you can't cure it, but we can help you manage it. And so our programs, I imagine your kind of value prop is like we help reduce like ED visits or downstream effects. Like you mentioned, suicide was a huge factor, which is great that you're working with those populations. So that's kind of the value prop, right? It's not like we're not going to cure this, but we're going to prevent all the other downstream stuff and be a good partner and steward of these patients we're seeing.
Yeah, absolutely. Right. So we often talk now about how addictions across the board, substance, gambling, other behavioral addictions, these are similar to chronic illnesses in that sense that we can't necessarily cure it, just like we can't cure your diabetes, but we can control it and we can get you on a path to being the healthiest you with diabetes or with high blood pressure or whatever other kind of medical condition you might have. And so from a psychiatry perspective, from a clinician perspective, that's what we really focus on is how do we optimize your level of functioning today, minimize the symptoms, optimize your functioning so that you can work, so you can take care of your family, so you can be a leader in your community, whatever that might be, and function at your highest level and maintain that recovery. Wasn't that long ago when people did think for an addiction, I'm going to fly out to California and go to treatment for 30 days and then I'll come home and I'm cured. And families crossed their fingers and hoped they could send their loved one across the country who needed help or whatever, and they'd come back cured. We know that's not the case. Payers are aware that's not the case as well. Really are starting to understand the long-term impact that being in recovery has at really helping you manage all of your other medical conditions, keeps you out of the hospital, keeps you out of the emergency room, those sorts of things.
Yeah, yeah, I love that. That's great. Do you guys think, because you guys are all virtual, is that correct? Like,
Correct.
do you partner with like in-person facilities, or like do you kind of vet quality of certain like rehab facilities or those sorts of things, or are you mostly just like, hey, we're gonna do this, and then, or how does that kind of handoff work if needed?
It's a really good question because as this prevalence has grown, or as access to gambling has grown, and I think prevalence has grown, you're seeing more people who need higher levels of care. And historically, there have been only 4 residential facilities in the US who have focused on gambling disorder, solely gambling disorder as a primary condition. And so that actually contributed to a lot of the cost of care that would emerge, where you had patients who might go to a residential facility where someone who is addicted to gambling or to sports betting would be put into the same residential program as someone who might be addicted to opioids, to alcohol, and unsurprisingly, care would not work and they would not hit and see the clinical outcomes which they've wanted. And so at Birches Health, we are a fully virtual program. We operate a telehealth model nationally, and today we operate the largest national network of providers who are actually specialized in these behavioral addictions like gambling and sports betting across the US. But we'll always refer people out when they come in and they're too high acuity to a higher level of care. And I think it's a model which works very well. We believe, of course, that this is a treatment model which has to be holistic for the individual, for their family members, for their community. And so if someone goes to a residential program, we're actually often will work with them after they depart the facility to make sure that they can stay in recovery for the rest of their lives.
Yeah, that's awesome. And something you mentioned earlier is almost like, it's very anti-capitalism of you, but very pro-patient, where you're saying we want to set them up for success month 4 to year 40 and use us less, right? Kind of thing. So it's kind of counterintuitive in a way, like as your model works and you engage these people who are dealing with addiction, they use you less, and that kind of doesn't benefit you. But I guess I would assume your counter to that would be there's so much demand here, like it's not a problem. So I don't know. Does that dynamic make sense?
Unfortunately, yes. And Doug, I would actually love your thoughts on this. We've never discussed this before, I don't think. But I think in specialty care, it's one of the places where, amongst others, you can see real incentive alignment between payers and providers, which, I think as all of us on the call might know, is not always the case as much as we want it to be. And so offering the highest quality clinical outcomes to patients, to members, such that they do not end up as these significant costs of care down the line is actually really compelling to everyone involved. And of course, and most importantly, just to hammer it home, to a patient and their family. And it's incredible. Like I believe with all of our providers that we're saving lives. And so, Blake, to answer your question, we're really focused on making sure that the right patient gets the right level of care as much as possible. And I think a lot of our payer and health system partners have been able to recognize that. And that's why they've been, we've been very fortunate that they've worked with us in the correct ways.
Yeah, I would just add to that, Blake. I totally agree with what Elliott was saying, and that alignment around getting people to the right care and getting them better is really what we're all focused on. Payers really recognize, and that's really changed the view over time, is we mentioned earlier, we had a big access problem. Everybody said there weren't enough providers in behavioral health. What payers really saw for many years was it wasn't even necessarily that there weren't enough providers. It's just people weren't getting to the right providers. And so somebody circling in and out of treatment or in and out of care, but not getting better, doesn't help the patient get better. And it also doesn't help the health plan or whoever's paying the costs for all that care, or the family and all the costs that they have, now invested in that care as well. So really that alignment around our ability to truly identify what's the issue that the individual patient has, get them to a high quality clinician who can address the issues in the right way with evidence-based treatments, get them to an optimal level of functioning, and hopefully manage their care at a lower level of care. Uh, Everybody wins in that scenario. So that's really where we start to align on that outcome, and really can set up for success with partnerships between people in different levels of care, like Elliott talked about, or even between different parts of the healthcare system that are treating different conditions.
I love that. And maybe that's a great segue into talking about, alignment and integration. And, I imagine there are a lot of, because mental health and physical health were treated as separately, and now we're kind of trying to mend that wounds over the sternum, so to speak. What advice would you give to, health systems or payers or anybody who's trying to integrate, mental health functionality into their practice? How do you see that kind of playing out best practices wise?
I think we've spent a lot of years now just trying to get, primary care physicians, pediatricians, obstetricians, cardiologists to screen for and ask people about their mental health, right? And probably most of us at some point in a healthcare visit with a doctor have been asked about depression and what we call kind of the PHQ-9 screening tool, right? There's screening tools for lots of conditions. Interestingly, I'm guessing that none of us, and probably very few of the people even listening, have ever been asked by their doctor, hey, how often do you gamble, right? How often has it ever been an issue for you, right? Yet maybe we need to start thinking about how we do that so we can start to identify people sooner before they have the serious complications, especially since now adolescents are starting at a young age. These are young people who don't go to the doctor a lot for other chronic conditions necessarily, but they may be putting themselves at risk here with their behaviors, right? So I was surprised this week when my dentist at my regular dental appointment asked me about my marijuana use. For the first time that's ever come up in a healthcare visit, but probably appropriately so. And probably another thing we should be asking more people about is as marijuana use has become more common and legal in many states, right? Gambling is on that same trajectory, right? And has the same potential risks and complications. And so something that's really important for us to think about, how do we work as a health system, especially with those people who have the frontline, more common interactions with people, to identify people who are at risk and may need to get an evaluation or get some help for their problem gambling.
Yeah, it's a great point. And you answered the dentist, you told him, you roll a joint a day, right?
Yeah.
No, I'm just teasing. Well, maybe you do. I don't know. I'm not here to judge. Just kidding. So something else that I can't help think about, this is a podcast after all, is the role that AI has to play in mental health. The populations we've been talking about, ages 11 to 40, a lot of them are using AI more than ever. And as are, seniors too, at an increasing rate. But as a result, it seems like a lot of these people are using AI for health reasons, and also mental health chatbots are very prevalent. So I'm curious from y'all's perspective, and when it comes to addiction, one, what do you guys see the future, like appropriate role of AI in the clinical setting?
I can talk that from the Birches Health model specifically, and then maybe hand it over to Doug for a broader view. But at Birches Health, I think we're dealing with higher acuity patients. And so a lot of the work we do, in particular in kind of what we consider the initial phase, is clinical in nature. And it has to remain so in many ways, as in our therapists are exceedingly trained and specialized. We upskill and work with providers internally to make sure that they actually deeply understand a lot of the, shall we say, nuances of treating gambling disorder and other behavioral addictions. I think what's more interesting, though, when you think about the wraparound and almost digital interventions which AI can deliver, is thinking a lot more on the subclinical and almost product side, where someone has been in recovery for 3 months, 5 months, 10 years. It is my personal belief, and I think this is reinforced, of course, in the Birches Health model, that someone should not be in therapy for the rest of their lives. And I would go so far as to say that I think a lot of our payer partners would agree with me as well for many different reasons. But that being said, people do need support. And in higher acuity behavioral health, they need support at times which are not 6:30 p.m. on a Tuesday. They'll need it at 3 in the morning on a Sunday evening when perhaps a football game is ended and they realize that they're not going to be able to buy food for the next week because they gambled it all away. That's a really good use case for AI support for subclinical and digital interventions there. And so we're spending a lot more time on the Birches Health side thinking about how can we use this most efficiently and most effectively to support the clinical outcomes from the clinical side of the house, which we're already maintaining.
Yeah, I love that. Go ahead, Doug.
In a general sense, those are the same conversations that we're having across the board from a mental health and a substance use perspective as it relates to the use of AI. We know all of us individuals are using AI to ask questions. Many people, one of the most common reasons people use AI is to ask them about what's going on. I don't feel right. Am I depressed? What should I do? I'm lonely. I'm anxious. I can't sleep, right? Whatever our issues may be, people are going to AI and seeking help. And so lots of people trying to figure out how do we address that from a general AI use case perspective? How do we identify people at risk? How do we make sure we give people good advice? The regulators are all concerned, as we know, about what are they going to do to protect adolescents and kids from risks with AI giving out bad advice and those sorts of things as well. But then from a treatment perspective, we're all very interested in, as Elliott was saying, how can AI and other tools support in between therapy appointments, in between group therapy sessions? How can it support an individual in the middle of the night, on the weekend, on a holiday, when they may be struggling with something or may just need some extra support or some extra tools to help them get through the weekend or the night and get back to their life, right? Until they can get back into the office or online with their therapist, right? So I think those are the things across the board from a mental health and a substance use perspective that we're all really focused on. There's nothing that was magic about seeing your therapist once a week for therapy at the same time for an hour. But how can we build from that and really expand our ability to support individuals and give them the help that they need?
Yeah, that is fascinating to your point around the once a week model versus like the, hey, like I'm triggered right now, or this, I saw this ad or this game just ended, like those sorts of things. It's more contextualized and more personalized. And so that's exciting to think about, where both AI and your model can fill in those gaps more flexibly. Is there like a kind of, ambient documentation play where like you can like take conversations had, and if there's privacy concerns, just like, shoot me in the foot from the beginning, but, and like develop better, characteristics of a gambling addict based on like all of these real time conversations, especially because they're captured virtually. That's, a good interface for documentation capture. Like, is that a potential opportunity for you guys to like work with, policymakers and create studies and those sorts of things on better care for addiction?
Does that make sense? It makes sense, and without a doubt. And I think a lot of the opportunity here, just in particular with some of the research and some of the data points which we're collecting through things like ambient scribing, is that there just hasn't been that much research compared to SUD, AUD, and OUD in particular, or other behavioral health, depression, anxiety, more general disorders. You just haven't seen that in behavioral and process addictions like gambling disorder, because gambling disorder, again, really only started to emerge into the public consciousness over the past 5 years since online gambling started to spread. And so, and I will say, given this is, we're recording this kind of at the end of April, yesterday, first bets at table games went live at a new casino in New York. So it's a very topical time too. And, as access expands, shall we say prevalence will increase too. And so when we think about what we're collecting, there's a lot of research to be done here. There's a lot of just like education, which I think you'll start to see in the field over the next 5 to 10 years. And at Birches Health, we're very happy to be at the forefront of that simply due to the data points we're able to collect across our patient population.
I would just add to that as a clinician, things like ambient listening and note taking and note support for doing that documentation, a huge benefit to the clinicians to make us as a clinician more efficient. We can see more patients, we can get more done. We're able to better take care of ourselves if we're not sitting at home doing notes all night on all the patients we saw that day, those sorts of things. And so that's all really great. From a system perspective, I hear lots of clinicians talk about the fact that how much better their notes and their documentation is now than it was when they had to do it by hand a few hours after they saw the patient and try to remember everything that they had talked about that day. And that becomes important just from a longitudinal perspective. As we said, these are chronic diseases. I may be your clinician now, and even for a number of months or a couple of years here, but when I leave or you move out of state or something else and you start seeing somebody else, the ability to share some of that information that's appropriate to share and that you want to share with new clinicians and the next ones to understand truly what your medical history was and your mental health and substance use diagnoses or treatment was that you received in the past that was successful or not as helpful, going to be really helpful from a long-term support and recovery perspective as well.
Yeah, I think that information exchange is so exciting and one of the coolest use cases for AI, just like the documentation, like, hey, we tried this before, it didn't work, or like, here are the characteristics that you align with from an addiction stamp. Like all those things are exciting for me, not only in mental health, but just like across the board, like all disease states. So very cool to hear you guys are, thinking about that. One other thing I want to bring up, because everybody also loves to talk about GLP-1s these days, right? But I have seen like some, the headlines and the articles and some studies on GLP-1s and addiction. I think there was a New York Times article that came out recently too. I'm just curious from a clinical perspective, have you guys treated patients with addiction with GLP-1s, or what's kind of like the current status of that from y'all's perspective?
I think we're monitoring it very closely. On the Birches side, I think there's a lot of opportunity there, but I think there's a lot more research, in my opinion, which needs to be done before we think about rolling it across our entire population, just Birches internally.
There's been lots of anecdotal reports. You can certainly, all of us probably know somebody who will say, gosh, since I started taking my GLP-1 to lose weight, I haven't drunk as much, or I haven't felt like drinking as much, or I haven't gambled as much, right? It happens. And so we see those anecdotal reports. But as Elliott said, we need a lot more research to truly understand what's the impact, how does that play across everything else that's going on with individuals, what does it mean for a population with a diagnosis, and those sorts of things. There was, I just saw an announcement within the last 24 hours as well about some research around a psychedelic for substance use and disorders as well. So we're going to see more research on different drugs and different interventions for all of these addictions, including gambling, and we'll be paying real close attention to the research so that we can make sure ultimately people have access to the right treatments when it is evidence-based and we know something that looks like it's most appropriate for whatever condition they may have, like gambling.
Yeah, I feel like in 5 years, we're all going to be on some form of peptide or psychedelic, Seems like it anyway. No, just teasing. But yeah, so one more healthcare related question for you guys. And then I have a more personal question I ask every podcast guest. But the last thing is just give the platform over to you guys. Like, what can we expect from Birches Health and, mental health in the future for the rest of 2026?
So I'll let Elliott talk about where Birches is headed too, but in general, I think what's really exciting, and we've touched on this a few times today, is the fact that we are really getting in the mental health world where we can start to personalize care and really get people connected to high quality care for whatever condition it is that they have. And as we evolve over the next year, over the next 3 years, we're going to see that continue to expand. Payers are going to get better at connecting people and having networks that get you to specialists for gambling, for an eating disorder, for depression, whatever condition it might be that you have. And not that generalists will get lost in the system or go away, just like primary care physicians still exist, but we'll be much better able to identify early and get people connected to the right mental health care. And hopefully we start to see more people screening and identifying people with gambling disorders and being able to make referrals to Birches and other specialists for gambling so that people can get to that care.
Could not have said it better myself. Fully agreed. But I think what's really interesting from the Birches side is that a lot of these disorders are so new. In particular, to which we focus less on today. Gambling disorder is kind of our primary clinical focus, but video gaming disorder, of which we do see significant co-occurring with gambling. And then also internet, online, and social media disorder are things we're thinking a lot about. And these are clinical disorders which really only have emerged over the past decade or so, given we now all live on our phones, for better or for worse. And so the opportunity to build out new clinical models in conjunction and co-development even with payer partners, with health system partners, that's really exciting for where the field of specialty behavioral healthcare is going over the next decade or so.
Awesome, guys. Well, really looking forward to seeing how mental health evolves over that time period and Birches within that. So super exciting stuff. And I do have one more question for both of y'all. Something I mentioned I ask every guest, and it is, what is an experience or piece of advice or book, something you've consumed that has fundamentally changed how you live your life?
Well, I'll go first for that. I would sort of go back to recently some online comments and reporting and talking from Marcus Freeman, the head football coach at Notre Dame. I have two kids who both went to Notre Dame, so I've become a big Notre Dame sports fan, et cetera. But after Notre Dame felt they got snubbed last year in the playoffs and didn't go to the playoffs, and people were talking with Coach Freeman about how do you get the team ready for next year, right? For the next season and keep people focused to prevent the depression and discomfort of not being able to participate where they felt they deserved it and things without just being angry at the system and angry at other people. The comment that he made was he needs to tell his players, and they focused on their mantra for the season around leave no doubt is the statement that they use. I leave no doubt. Don't let the polls and the rankings and things decide. Don't give the people who choose the playoff teams an option not to choose us, right? Leave no doubt in their minds. It brought back for me, actually, it really coalesced when my kids were younger and they were in school and in sports. And one of the things that I often said to my kids and was sort of how they would perform and when they got nervous about things was, that same comment I would tell my kids, leave no doubt, whether that was a sporting event and they were nervous, would they win or not, just, go out there and leave no doubt. If you're taking a test in school and you're worried about, am I going to get a good grade or not? Just leave no doubt, right? And that has carried on into work as well, right? If you're doing a project at work, if you're giving a presentation to the CEO, whatever it might be, we all get nervous in all of these types of situations, right? But across the board, regardless of what kind of situation, is that sort of internalization of, hey, I'm just going to go in there and leave no doubt I can do this. We can be successful at it. And even though some things aren't going to go our way, we all lose, we all don't get a job sometime, right? Whatever, that ability to say, just leave no doubt, I've done everything I can do for it, and move on from there. So that's the one I'll share. And it'll be fun watching Notre Dame in football next season next fall to see if that works for them as in their season as well.
Yeah, but best of luck with Notre Dame. But my Texas Longhorns, Arch Manning, they're gonna take the ship. So just so you know, just so we're all clear on that.
All right.
Just
We'll
teasing.
see.
No, that's great advice.
I have a cousin who is actually a professor at Notre Dame right now, and I'm angling for a pair of tickets. So maybe I'll see you both there at some point in time. But I think I'd go back to just one of the reasons why I started the company, Blake. There's this incredible long form article, I think from now maybe 2 decades ago. It must have been kind of 2010-ish, I think. It's by an author, Jay Kang, and the title is about it's about gambling addiction, unsurprisingly, and the title is "The High is Always the Pain, and the Pain is Always the High." And I reread it probably once every 6 months or so since starting and now running and scaling this company. And everyone who joins Birches, we suggest them reading it too, because the way he phrases it is that it's a chronicle of dependency. And the hero's journey, almost in some ways, of encountering an issue in your life, going through a descent from it, and then kind of reemerging, is really powerful. So that's kind of the recommendation. And I also think it's a metaphor for building a very quickly growing healthcare company and health or startups in general as a whole. Not everything is perfect, but by and large, I think if you align yourself with the right people, you make it out okay.
Yeah, that's awesome. I love that. I'll definitely link to that article in the show notes. And so thank you for that. And I will read it. And I will leave no doubt about that. No, but guys, thank you so much for your time today. Best of luck to Birches in the Birches Health in the future. Really learned a lot. Thought it was a great conversation around addiction and payer involvement and all the things in between. So thanks so much for your time, and hope to be in touch in the near future.
Thanks, Blake.
Thanks so much, Blake. Great to chat.